So, good evening, everybody. You're all very welcome to our Facebook Live talk tonight. And tonight, I have a very special guest. Dr. Suzanne O'Sullivan has joined us to tell us all about bladder problem. Dr. Suzanne O'Sullivan is a longtime colleague and friend of mine, and she is a consultant in obstetric and gynecology with subspecialty in urogynecology. She's been looking after women and bladder problem for a very long time, and she has also been very recently president of the Incontinence Foundation of Ireland. So good evening, Suzanne. Thanks very much, first of all, for joining us tonight and answer all the questions we got in for you. And I suppose I just want to say that the reason why I asked Dr. Sullivan to come and talk to us tonight is because, in my experience, the bladder problems is something else that women are very afraid to talk about, a little bit like the vaginal problems that we discussed last week. And so we just wanted again to try to bring down barriers and, to make sure that people are comfortable in discussing all these issues. And that's why we asked her to join us tonight. So, Suzanne, I suppose the first question I have for you tonight is urinary incontinence. How common is it, and what is it? What type of medical problem is it?
Okay, well, firstly, I'd like to say, Rita, thank you so much for having me to talk on a topic that's very close to my heart. Urinary incontinence is a very common problem, and almost 1 in 2 women in their lifetime will suffer from urinary incontinence. So it's a very common problem. Now, obviously, it can affect people in different ways. Commonly, women will experience it during pregnancy or postpartum, and then it will settle down and they'll never have a problem again. But it is a very, very common problem. There are 2 main types of incontinence that we see with women most of the time, the vast majority of the time. The first one is of stress incontinence, and I have a slide that Rita is going to show. And the definition of stress urinary incontinence is the involuntary leakage of urine on effort or exertion or on sneezing or coughing. And this is probably the most common kind of incontinence that we see and that people report. The other kind of incontinence is called urge urinary incontinence. And this is the complaint of involuntary leakage of urine accompanied by or immediately preceded by a sensation of urgency and having to rush to the toilet. Now, because they're both quite common problems, there's quite a lot of overlap. So we would often say just under half women would have, the patients that we would see in clinics will have stress incontinence purely. Just under a third will have mixed stress and urge incontinence, and just about a fifth of patients will have pure urgency and overactive bladder. And that's actually probably a slightly old side, because as the population is getting older, urge incontinence and overactive bladder symptoms are becoming much more common. So that number is certainly changing presently, and is going to become a bigger problem as women live longer and have longer life spans after the menopause. So common problem, 2 different types, but quite a large overlap as well.
Thanks for that, Suzanne. And can I ask you, is it important to know which one you have, or does it matter, or why is it important to know?
Okay, well, I suppose from a woman's and from a patient's perspective, incontinence is incontinence is incontinence, and no matter where it comes from, it's extremely distressing. However, from the perspective of seeking help and getting information about what's the best options and approaches to treatment, and certainly from a clinical perspective, the differentiation between the 2 types of incontinence is absolutely paramount, because the treatment options are entirely different. So if we look at stress incontinence, the problem is in the connective tissue and ligaments supporting the bladder neck to the pubic bone, and therefore treatments are aimed in that direction. If we look at urge incontinence and overactive bladder symptoms, which is quite a larger spectrum of the same problem, the issue is within the wall of the bladder, and it's to do with the nerves that supply the muscles that cause the bladder to contract normally when we empty the bladder. However, with urge incontinence, those contractions happen out of the blue when people aren't prepared and when they're not sitting on the toilet. So the difference is, I think it's important for patients to understand the difference, but it's extremely important when we look at therapy and how we're going to approach and treat the problem.
And Suzanne, how do you know which one you have? Is it, Is something the
Well,
patient will know or something that the doctor will decide?
okay, so the patient usually doesn't know. But again, especially in our younger cohort of patients, they're much more knowledgeable nowadays. And there is more information out there about urinary incontinence and the problems, and people can Google and get information. But again, often it's poorly understood. So again, I think when patients are seeking help, to be able to actually explain the problem and make their understanding as good as possible improves buy-in to the treatment options that are available. And again, some of the treatments involve quite a lot of work, some of them involve taking medication. So it's really important that the person understands how the treatment is going to work, what's called, and how it's going to improve their problem. So the understanding the differences between the types of incontinence is really important. So in terms of patients finding out information, there are very good websites like on overactive bladder. There's a website called oab.ie. Again, in terms of stress incontinence, the first line of treatment might be physiotherapy, and there's information about physiotherapy out there online as well.
But apart from their understanding, is there a test you can do to know which one you have, or how
Yes.
do you decide? And what do you do
So
if you
there
have
is
a
a
bit
test.
of both? How do you know if you have a bit of both?
Okay, so normally in terms of the history and the description of the complaint is really important. But in terms of absolute diagnosis, there is a test that can be done, and that's usually done at a hospital level by a subspecialist, either a urologist or urogynecologist, who specializes in treatment of urinary incontinence, and that's called urodynamics. So that's quite an advanced test where a tube is put into through the urethra into the bladder, and another tube is put in either to the vagina or the back passage, and the bladder is filled with water with pressure monitoring that measures the pressure within the bladder and without the bladder. So if the bladder is contracting at the wrong time, that is measured, and we can see where the patient is having urge incontinence episodes with the muscle of the bladder contracting. And that can differentiate between the problem of urge incontinence and stress incontinence.
Yeah, and I suppose about that, Suzanne, is it something that you always have to do? Do all patients have to go to this test, or can they discuss the treatment with the doctor and see how they go and decide to do them at the second stage,
Yeah.
or do they have to do it as a first step before they do anything else?
No, absolutely not. So most people will come to their GPs with the problem in the first instance, and there are very simple algorithms of treatment. So if the problem is mostly stress incontinence, the first line of treatment is physiotherapy. And physiotherapists can actually be very helpful with overactive bladder symptoms as well, because specialist physiotherapists are treated in the approaches of conservative treatment of all types of urinary incontinence. So especially with stress incontinence, the first line is physiotherapy, but it's not just any physiotherapy. And this is a big mistake a lot of people often make. They go to their local physiotherapist who may not be a specific specialist women's health physiotherapist. So if you are looking at physiotherapy, or either your GP can advise you on the appropriate physio for you, or you can go onto the website of the Chartered Physiotherapists Association of Ireland, and that will give you a list of all physiotherapists who are specifically and specially trained in women's health physiotherapy in your area. And the difference with those physios is that they will examine you vaginally, and they will actually look at how the pelvic floor muscles are working, whether they're too tight, whether they're not working at all, and they will give you targeted and focused treatment for your problem. I suppose very frequently people come in, or we get referrals saying they've been doing pelvic floor exercises for a very long time, and then I might examine a woman, and when I examine them, I always do a vaginal examination, and I always ask the woman to squeeze so I can assess the pelvic floor contraction. And often they'll have been working really hard for years on their pelvic floor exercises, but they're squeezing their buttocks and they're squeezing their thighs, and the pelvic floor muscles are not contracting at all. So it's a shame for people to waste their time doing the wrong treatment for long periods of time, and sort of not get going anywhere. So that's the importance of specific specialist targeted physiotherapist by a women's health physio.
And I suppose, Suzanne, one question I get asked quite a lot by patients is, is the little thing that can make me understand. So, that thing that the doctors say about the key in the door syndrome, or, for example, if they leak when they run, all women are convinced that must be stress incontinence. And
Yes,
you told me
yes,
before that that's not the case. So can you tell us a bit more about that? So, because I think that's important for women to understand. Most
yes,
women think, oh, if I leak when I jump or run, has to be stress incontinence,
yes.
and it's not like that.
Okay, so that's often the case. And as you say, and as we've said already, the history is really important. So when we talk about urge incontinence, it's one part of the spectrum of overactive bladder symptoms, which is a much bigger and much more common problem. And it affects both men and women equally, especially in older age. So typically, urge incontinence is associated with people, women who have to go very frequently. And they often, because the urge is quite strong, they start going just to try and avoid episodes of incontinence. Now, this also happens to women with stress incontinence. So they feel that if they go more often, the bladder will be emptier and they're less likely to have a leakage episode. But that's actually not the case. And often when they get into that behavior for a very long time, the bladder can shrink, and that is not good. So when you're trying to differentiate, you'll ask how often somebody voids. So more than 7 times in 24 hours would be considered higher than our normal, our usual numbers of voids. Whether people have to rush to make it to the toilet when they get the urge, are they able to finish what they're doing, or do they have to drop everything and run? And if they leak or have episodes of leakage or accidents before they make it to the toilet. So that's classical of urge incontinence. These women also often have to get up at night to empty their bladder, and they have a sensation of having to, void more frequently and really rush to get to the toilet. Now, women with stress incontinence, and as I say, there's also a very large overlap of just under a third of our patients have both, but women with stress incontinence will also void just in case. So I'm going out and I'll go now so I don't get caught later, or, they're in town and they see a toilet and they say, well, they'll go now so they don't get caught again later on. So that again is not good for the bladder, because the bladder's function is as a storage organ to store urine, and the more it can hold, the better, because then you leave the toilet less, and that's the whole job of the bladder. So again, the key in the door incontinence is typically urgency. It's typically associated with urge incontinence and overactive bladder. So women know they need to go. Psychologically, they know they're close to the toilet, and then the bladder contracts and they have the key in the door leakage.
Great, Suzanne. That's really clear and very helpful. Thanks. So let's say that you have gone to your doctor. They told you have urge incontinence. You thought you had stress, but it's urge incontinence. What do you do then? What do you still have to go to see a specialist? How does the treatment start?
Okay. So yes, going back. So most of the first lines of treatment should be done in the community by the GP. There are nurse specialists out there who can give care as well, and physiotherapists. So the first line in terms of overactive bladder is bladder retraining. And there's a very helpful website called oab.ie, and it gives information about the problem and then how to deal with the problem. But typically, you want to get out of the cycle of going all the time, because that's just going to lead to the bladder shrinking over time. So we'd say to women, just every time you get the urge, just try and push it out a little bit longer. And it's very difficult at first. And if they're getting up several times at night, just stay in bed. And a lot of especially older patients will come in and they say, well, I don't sleep well, and I wake up and then I feel like I can't get back to sleep unless I empty my bladder. And they get out of their cozy bed and sit on a cold toilet and wash their hands with cold water, and they're wide awake getting back into bed. But there's a psychological imperative to get up. So I would talk to them about holding on, increasing the length of time between voids, reducing the number of voids, gaining confidence that they can actually go longer, and stopping them getting up at night, because especially in the older population, getting up to empty the bladder at night is a big problem and is a major cause of falls in very elderly patients. So also we'd look at fluid intake and the kind of fluids and foods that are more irritant on the bladder. So some people are drinking 3 and 4 liters of water a day, and yes, they need to go 10 times a day, because their bladder is working normally when you look at what they're drinking. We can do a bladder diary, which measures what's taken in, and then the volume of each void. And that can be very, very helpful. And it's a very simple thing to do. And it allows people then to get biofeedback on how they're doing. So if they do a diary at the beginning of treatment or an intervention, and they see that they're passing 100 mils every hour, and then they can measure their progress themselves, and that's extremely helpful. And as I say, fluids like caffeine are really irritant on the bladder, alcohol, fizzy drinks, citrus juices, chili and spicy foods can cause a lot of irritation on the bladder. So looking at those in interventions and changing lifestyle and habits are very helpful.
Yeah, we just got a question in about that. Actually, a patient is asking about if there is any agent that are irritants to avoid. So you answered that very well for the patient. So you can continue. Sorry, I just wanted to make sure that we said the question. Yeah. So, and what about, so we said about all of those things. What about medications and all of that? Do you need to see a specialist for that as well? Or is that something you can do?
Well, at that stage, it's time to see your GP, because the first thing that you need is, it's important, if those interventions have not worked, it's important to have a urine specimen and a urine test done. So that can rule out infection, but it can also rule out either red or white cells in the urine, which may require further investigation. And that's certainly important, especially to women who are over the age of their mid to late 40s and who are smokers. So as I say, the first intervention, bladder retraining, you can do that online and get advice with that. But the next step is going to involve a doctor. So a urine specimen needs to be done. An examination needs to be done. So, simple to rule out pelvic tumors, to rule out very bad prolapse or something that's actually causing the problem. Now, most of the time, the problem is just within the bladder, and assuming that the urine is clear and the examination is negative, the next step in terms of treatment is to look at medications. And there are lots of different medications out there. They come from two main families, but the aim of the medication is to work and to calm, I suppose I say calm down the nerves that supply the muscle that contracts the bladder. So we're looking at treating at that area to try and calm the nerves down so the bladder is contracting less. And as I say, there are lots of different medications. Now, they're very, very useful and very safe medications, but they all have specific things that you have to be careful about. So one kind of medication can't be used with a certain type of glaucoma. Another medication should not be used with certain drugs that are used for heart arrhythmias. And it's very important that you have your blood pressure checked as well before starting medication.
Thanks, Suzanne. And if somebody starts medication like this, is that something that they do for the rest of their life? Or at some stage, can they stop them? How do they decide what to do?
Okay, so again, it's important that when somebody starts medication, often patients think it's a course of medication. It's not. It takes actually 12 weeks for the medications, all of them, to fully have their effect. Now, the best way they're going to be work is if they are done alongside bladder retraining. So the medications by themselves will improve things. But again, the bladder retraining and getting out of the habit of constantly going is really, really important. So using bladder diaries to look at symptoms and measurements and bladder volumes before and after treatment is useful. But a small number of patients will be able to take medications for 3 months, will be able to come off medications and will be fine with no symptoms for the rest of their lives. But most people with true, especially urodynamically proven detrusor overactivity will need medication in the medium to long term. And that will allow the bladder sensation to settle. It will allow the bladder to get used to holding larger and larger volumes, and it will keep those nerves and muscles relaxed and allowing the bladder function to normalize. So it's often a bit like blood pressure. If you come off the medication, you'll go backwards. Not always, but often. And if you stay on the medication, then you're likely to get a better long-term result.
And Suzanne, in terms of our population age of women who are in menopause, does the HRT play a role in urge incontinence, or is that something that is completely separate?
HRT is, well, again, the vagina and bladder and pelvic floor tissues are full of estrogen receptors, and the bladder really misses estrogen when women go into the menopause. And that's one of the reasons why overactive bladder and urge incontinence is a much bigger problem from the menopause onwards, with numbers increasing exponentially with each decade. So using the evidence on cure of incontinence with HRT is not black and white, but it certainly can help somewhat, and it can help both stress incontinence and it can help urge incontinence, and it can certainly help about urinary tract infections, which are often again a problem that mixes in with patients who have incontinence. So it is helpful, but it's not going to necessarily give a cure by itself. So as a part of a combination and a suite of treatments, it can be extremely helpful. And it doesn't have to be systemic HRT. Local vaginal estrogens are extremely useful in this cohort. And not only will they help the bladder, but they'll help other symptoms in terms of sexual dysfunction and vaginal dryness as well.
That's great, Suzanne. What about stress then? If you have stress incontinence, is that the same thing? You take medication, or what do you do?
Okay, so stress incontinence is entirely different to urgency and overactive bladder symptoms. Stress incontinence is, as we said, it's usually associated with exertion. So either exercise, coughing or sneezing. Some people who have very severe stress incontinence, even if they laugh, they'll have an incontinence episode. So again, it's a wide spectrum. It's very common in women after pregnancies and also after vaginal delivery. And often they will experience symptoms for a few months, and then they will improve and they'll get back to normal, but obviously some will not. So the first line, as I say, of treatment is going to be physiotherapy, and it needs to be the right physiotherapist. If physiotherapy does not work, then the next line is going to be either looking at laser therapy or looking at surgical interventions. Now there are okay.
Sorry, I just want to ask you something about the physiotherapy, because I know you said it before, but I think this is a really important point. When we talk about physiotherapy, it is important it's the right one and women do their exercise correctly, because otherwise they could be thinking that the physiotherapy didn't work, but they actually didn't do anything at all. Would that be correct?
Yes. So when I say physiotherapy, that does not mean pelvic floor exercises. From an intervention point of view, I would be very slow to do anything more on somebody who has not completed a course of physiotherapy with a specialist physiotherapist. So that's a very specific course of treatment that needs to be done by a specialist. And we actually have good data that shows that up to 70% of women will be significantly better or cured by the right physiotherapy.
That's great. And you were saying about other forms of treatment, if that doesn't work?
Okay, so if physiotherapy doesn't work, we can look at laser therapy or we can look at surgery. So I suppose in terms of invasive treatments, laser therapy is a lot. It's a non-invasive treatment. It's walk in, walk out. It's very well tolerated, and using Photona erbium laser, the safety profile is extremely good. However, we're still talking about numbers of around 70% with a significant improvement or cure of their symptoms. The downside, I suppose, with laser is that it is not going to be permanent. It's like laser used in cosmetic surgery or cosmetic intervention. The laser will work on increasing turnover of connective tissue and turnover of collagen, and improving the urethral support of the bladder neck, the bladder neck and urethral support along the vaginal wall, holding it up against the pubic bone, which is sort of the mechanism of urethral compression and urethral continence. So, but the problem is that, as I say, it's not going to be long term. So in patients who do really well, we often have to look at doing top-up treatments every 2 or 3 years. The other thing is that it may not work, but the safety profile is extensive, and yes.
And in terms of being successful or not, is there any factors that makes it more likely to work for a patient, or the same for everybody?
So, the evidence certainly would suggest that mild to moderate incontinence will do better, and that's probably not unreasonable. Severe incontinence the results are not as good, but I have had patients with severe incontinence who were completely unsuitable for surgery and who chose to try laser and who've done very well. So it does vary. It really does vary.
But I suppose there's other things as well in terms of how old are they, if they're overweight. Is there anything else they can do themselves to make the situation better, to be candidates for treatments?
Okay, well, I mean, in terms of weight, it's a big problem for both stress incontinence and urge incontinence. So, a first or second line of treatment, if somebody is overweight, weight loss will improve their symptoms drastically by itself. So, obviously, and that's easier said than done. We all know it can be really hard to lose weight. But yes, weight loss is important and is likely to significantly improve outcomes. But that goes for physiotherapy, that goes for laser, it goes for surgery as well.
Okay. And in terms of laser, how long does it take for it to work? How much laser do people have to do?
Okay. So the course is usually 3 treatment sessions, and so we do the first treatment session at 0 time, the second treatment session about a month later, and the third treatment session after 5 or 6 months after the first treatment. Now, sometimes there will be, because it works by heating water in the cells of the pelvic floor and the vagina. And it's very important, again, looking at laser therapy, there are different types of laser, and there's quite a lot of controversy on it in the media and certainly online. So there's a carbon dioxide laser which works differently, and it works by ablating tissue. So it causes a sort of a superficial or mucosal injury and works that way. The erbium laser does not. So it works by heating to about 40 degrees, and therefore it's a much, much, much safer procedure. What that does is it improves blood supply, and it starts an increase in turnover of fibroblasts and cells within the pelvic floor that, again, we sort of feel to a certain extent that as we age, that, certainly with the pelvic floor, that your connective tissue gets looser. That's actually not the case. What happens as we age often is that your connective tissue, your collagen links become much, much tighter, and you lose elasticity. So again, there's a reversal of that change in terms of the connective tissue of the pelvic floor, and an increase in collagen turnover, an increase in blood supply, an increase in thickness of the mucosa, all of which again improve the compression of the urethra and improve the continence mechanism. And then there's the beneficial side effects of reduced vaginal dryness and the changes with the vagina as well.
That's great. And is there anybody that cannot have the laser? Is there any reason why somebody should not try, or it's contraindicated for them?
I suppose maybe patients who've had previous surgery, because I think that the laser is not really going to work on them. Not because it's going to be harmful, but I do think that it's significantly less likely to work. And, when you're starting an intervention, you want to have a good chance of it being successful. I suppose for patients who've had cancer, and who are having follow-up for either cervical cancer or vaginal or endometrial cancer, patients who've had radiotherapy, there just isn't very much data on. So again, I'd be careful in that group, but no other really specific contraindications. I think it's really important that women considering the treatment get the right information. They get the right evidence-based information that's available, and that they choose carefully the kind of laser treatment that's offered, because there are some treatments out there that concerns have been raised about, and that's very important. The Fotona erbium laser that you use and I use has been backed by the Canadian Medical Association recently. There's a lot of ongoing research into the treatment, and certainly its safety profile and the studies surrounding it are very, very, very reassuring, I think.
That's great. And I suppose it's important for people to remember that this is a medical treatment, not a cosmetic treatment. So to look carefully who does the treatment and who gives the treatment, has to be a specialist, and that's not always the case. Suzanne, you mentioned urinary infections before, and I suppose when I put the sign up for bladder problem, is something that women think about a lot. So when they think about bladder issues, not just incontinence, a lot of women have recurrent urinary infections or chronic infections. Can you tell us about what the infection problem fits in all of this?
Okay, well, I suppose women are uniquely more vulnerable to recurrent urinary tract infections because we have a very short bladder neck in comparison to men. And we'll often see in younger age groups this honeymoon cystitis, which is urinary tract infections that seem to be precipitated by intercourse. And that's quite a common problem, but actually it's a very common problem in women after the menopause as well. So we certainly see recurrent urinary tract infections more frequently as women age. What can often happen is that a very severe urinary tract infection can be difficult to clear. So a short course of antibiotics will get rid of the symptoms initially, but then they appear to get infections back at a regular basis. And for those patients, well, first and foremost, it's most important before any antibiotic treatment is given that a urine specimen is sent to the lab. So that's hugely important because especially with the evolution of antibiotic resistance, more and more commonly, people are taking courses of antibiotics for an infection that the antibiotic is not sensitive to. So don't just take antibiotics for a urinary tract infection. Make sure that a urine specimen goes to the lab. A dipstick is not enough because that will not, confirm that there's an infection there. So we look for two things with a urine specimen that goes to the lab. We look for pus cells, and if there aren't pus cells, actually there's no infection there. And the other thing we look for is bacteria. But the pus cells are important because often when people take specimens, bacteria will be picked up from the skin on the way out. So it may grow bacteria, but if there are no pus cells, there's no infection. And sometimes people can feel like they've got an infection. There can be a sensitivity, again, especially in the postmenopausal group, or in people who've had a recent infection where there's still a bit of inflammation going on, but then more antibiotics is not going to help that. So it's just important that you get the right treatment and that the right antibiotics are given, especially to reduce the problem of antibiotic resistance over time.
Yeah, and I suppose the antibiotics is important because we know we live in an era where there is definitely an overuse of antibiotics.
Absolutely.
And it is very common in emergency room or in primary care sometimes to be given an antibiotic because you have the symptoms. Okay, I think we covered a lot. Yeah, sorry, go ahead.
Sorry, just for women with recurrent infections, there are some very basic interventions that they can organise themselves. So in a large pharmacy or health food shop, D-mannose is a product which has been proven to, it reduces the ability of E. coli to travel from the gut to the bladder. So it's a natural remedy. It's not a prescription remedy, and it has been proven to significantly reduce the rate of recurrent urinary tract infections. And also I would very frequently recommend a probiotic, which actually is a probiotic for the urinary tract flora. And it's called BioCult ProCyan is the one I use frequently. I'm sure there are other ones out there. But again, they're simple interventions that can just, again, help the rate of recurrent infections disappear. Otherwise, then we usually are looking at low dose, long-term antibiotic courses. And again, that it's nicer to avoid that if possible. And again, we've mentioned the use of local estrogens, and certainly local estrogens can be really helpful in these patients.
Right. We have a comment from a patient here, Suzanne, or somebody who said she was due to have the surgery and it was cancelled, and she wasn't given any other option. I suppose for these patients, it's important to know that the laser is an option and it's something they can try in the meantime.
Yeah, and there has been a suspension on surgery recently, but we're very much expecting, we've been working hard with the Department of Health, and we're expecting to be getting back to providing surgical interventions with to the patients who need it. So that's very much on the horizon very soon.
And I wanted to ask you, what's your opinion on all this advertising of incontinence pads, Suzanne, because it seems to be in the media, and certainly I've seen an article or something on the Irish Time, I think it was, on what women should wear, and it was like to me a little bit offensive because I just felt it was like, well, that's your solution, wear a pad. And what's your opinion on that?
Okay, I'm amazed at what I've noticed in the last probably year with the increase in the number of these ads. I find it actually really distressing, and trying to make, there was one particular ad where a mother is wearing a nappy, lifting her baby out of a cot who's wearing a nappy. And I feel that there's a strong move in the media to trivialize urinary incontinence and to make it normal and acceptable. And obviously the people who are paying for these advertisements have a vested interest in it. But what I think is, as a woman as a mother and as a doctor who has worked very hard all my life with this problem. It's unacceptable at every level. So I think it's really insulting. You know, some of the ads are again, I find it hard to get words to describe them. But what I think is really important is that women know that they're not alone and that there is help, a lot of help out there. And as I say, not all of it is with subspecialists in hospitals. Most of the people who actually seek help, you know, and most of the people I'd often see can actually be cured or pretty much sorted out by very minor interventions and an understanding of what's going on. We briefly mentioned as well, there's a great product out there called EVB Sport Shorts. And this is a product that is made by an Irish female engineer, actually, who suffered from the problem. So it's evbsport.com. But basically, they're engineered shorts, and they're for women with incontinence and prolapse. And what they do is they elevate the perineum, which is the body of tissue between the back passage and the vagina, and they pull it up when people are exercising, and that gives increased pressure to the bladder neck. They can be used if it's not fully supportive just by itself with a tampon, and allows women who have, especially if they've got milder incontinence and maybe the risks of intervention might outweigh the benefits because they only get problems very occasionally. But for exercising and sporty, you know, our patients awaiting treatment or undergoing physio, there are some other products out there like that that can be really helpful. So I would very frequently recommend EVB Sport Shorts because, again, they're safe. They don't work for everybody, but they work for a large number of people, and they will tide women over and allow them to get on with their lives, allow them to do the things that they enjoy to do, especially sports and exercise, because it's bad enough if you leak, but then you have the, you know, extra knock of not being able to do what you like to do.
Yeah, a patient has actually just commented live to say that she has the shorts and they're fabulous. So that's great to hear. And just to be clear, nor myself or Suzanne have any investment whatsoever with the company. Just I think it's important to clarify that, Suzanne, just to think that people say we're trying to sell them. We have nothing to do with them, but they are invented by a woman and they work really well. And everything that we see that works for patients, we try to recommend it. Suzanne, that was very informative. It was great. I have received a good few questions during the week of women that have put a question during the week. I've asked women to send a question in advance because sometimes people are embarrassed to put their comments up live because you can see their name and all. So I picked a few because there were so many, and I'm sorry that we can't go through all the questions. Like always, you have to pick some. So I picked some that I thought were quite interesting. So I'm going to ask you that if you don't mind. A patient asked me, and said she had a baby at 2 years of age, and she has what she thinks is stress incontinence. Now, obviously, we don't know how she's been diagnosed or not, but she was wondering about being treated and having the laser because she hasn't finished her family, and she was wondering, should she finish having children, or is that something she can try because she doesn't know when she wants to have her next baby?
Okay, well, I suppose a few things just about pregnancy and having babies. So if we start at the very beginning with this woman, so it's very common to have stress incontinence after babies. And actually, after a vaginal delivery, it takes 18 months for the pelvic floor to fully recover. So if you think that your connective tissue in the pelvic floor and the vagina has gone from a normal size to 10 centimeters and back again, that process isn't instant. The other thing that happens is as the head is crowning, the nerves that supply the pelvic floor muscles can sometimes get pulled off those muscles. And often we'll see women postnatally and we ask them to squeeze during a vaginal examination and their pelvic floor muscles do nothing. So that nerve regrowth takes 18 months to happen. And whilst physiotherapy is very important, sometimes we see instances where women have physio very early on, but the nerves haven't actually grown back into the muscles. And before doing something, you know, if they've had it very early on, I would look at having physio again after 18 months, because they may actually at that stage be able to improve their pelvic floor tone that they wouldn't have been possible before that. Now that's not across the board, but that would be one approach. So certainly in terms of the laser, it's a very reasonable treatment, but obviously the woman needs to be absolutely sure she's not pregnant because it cannot be done in pregnancy, and with the understanding again that while it's safe and, you know, there's a good chance it will be effective, the pregnancy and another vaginal delivery is going to undo that work. So it's certainly a good medium-term option, but it may be a lot of investment for something that is, you're not, that a pregnancy is likely to undo or to reverse a little bit. So it depends on how long you're looking at in terms of having your next baby. If it's going to be soon, maybe a better wait, but if it's going to be a few years, absolutely, it might be worthwhile, very much so.
That's great, Suzanne. Thanks. Another question I got in during the week was in relation to buying pelvic toners or electric stimulator. I think the patient called them. I'm not sure which one in particular she was referring to, but I suppose there is a lot of stuff available on Amazon and the internet that the women can buy themselves. What's the advice on that?
The advice for me is very black and white. Don't buy anything unless you're getting advice from a specialist physio. So instead of buying stuff online, because again, a lot of these things, they rely on you contracting your pelvic floor muscle. So a lot of the feedback devices, and again, you could be just squeezing your buttocks and thinking that you're getting a response there. So I would say, don't go on Amazon, spend your money on the right physio, and you'll spend your money much more wisely.
That's great, Suzanne. And one more question, and I think this is quite an embarrassing problem, which is why I was sent in advance, but I've seen it myself in patients, so I think it's important we talk about it. A woman who's quite young, she's in her early 30s, is describing having leakage of urine during sex, which is obviously very distressing. And I suppose maybe we'll talk a little bit about that and what can she do.
So leakage with intercourse is a really important question from a clinical perspective. So, and it's one that actually is really useful in differentiating whether somebody has urge incontinence or stress incontinence. So typically women who leak with penetration suffer from stress incontinence. So it's a really good symptom and question to ask in terms of helping differentiate the two types of incontinence. So women with stress incontinence are more likely to leak with penetration, but women with urge incontinence are more likely to leak with orgasm. And again, it goes to the problem with the mechanical or physical problem of the bladder neck with stress incontinence, and the neurological and neuromuscular problem that comes out of urge incontinence and overactive bladder. So not all women who have incontinence will leak with intercourse, but knowing which kind, if that would lead me, for example, towards looking at medication, because if somebody leaks with orgasm, getting rid of coffee and things like that is not going to work for them. They're very likely to need medication.
That's great, Suzanne. And the other question I had, I think you kind of answered it already. Another patient was asking how long after having a baby should she wait before seek for treatment. So maybe go over that again.
You need to give 18 months. Again, the pelvic floor is improving and recovering by itself. Even if you did no physio and you did absolutely nothing, it is getting better slowly, obviously at the very end, but it is improving all that time. And as I say, those nerves grow very slowly, and we know the rate at which they grow. And it's by 18 months, full nerve regrowth should have happened. So as I say, you'll know you're going to be as good then. And again, it's a good time to consider a top-up physio if you still have symptoms.
Suzanne, that was absolutely fantastic. I think we'll finish off here because I know Dr. O'Sullivan is busy and she has to go off, as you can see, at delivering babies and doing all the stuff that she's busy doing in hospitals. So we don't want to keep you too long. But I suppose my end message, and I would like to know what your end message is. My end message on this is for women. Please don't keep this problem. There is help out there. There's very good treatment available. And while it's very embarrassing for you, it's nothing we haven't heard before. We hear this stuff all the time. And we really very much would like everybody to be comfortable in coming and talking to us about urinary incontinence.
Yeah, I completely agree. There's nothing worse than seeing somebody who's put up with symptoms for 10 years and then with one intervention, they're better.
Yeah.
And they could have been dry for 10 years. It's a double slap in the face sometimes. So yeah, absolutely. Whilst it's common, it often, I suppose in my experience, it creeps up on people. They start after having babies and they get it at the very odd time, but it's not much of a bother. And then sometimes it just becomes a bit normal and a bit expected and not sort of thought about too much until it gets quite severe. So whatever stage you're at, just realize that help is there and that it doesn't involve major interventions like surgery. Most of the time it can be done with minor interventions, as I say, physiotherapy, bladder retraining. There's good information on the web, online. As I say, for the overactive bladder patients, oab.ie, it stands for overactive bladder. That's a great website. And there's another super website called awake2p.ie, and that's for people who have problems getting up frequently at night.
Yeah, what I might do, I might put those links and the links about the shorts at the end. Maybe I'll post it tomorrow as a link. Suzanne, thanks very much. Thanks for giving us your time. And
my pleasure.
Thanks a million. And goodbye, everybody. I hope you all enjoyed that. If you have any more questions, send them to me in the next week, and I'll put them to Dr. O'Sullivan. If she's not too busy, she might answer for us, and I can put the answer on Facebook. Okay? Good night, Suzanne. Thanks very much, and good night, everybody.
Thank you, Rita.